Lemieux, Chief of Pediatric Neurosurgery at Westchester Medical Center and Surgical Director of our Pediatric Epilepsy program here at Fareri Children's Hospital. I'm also an Associate Professor at New York Medical College. I'd like to talk to you today about some of the surgical options we have to treat pediatric patients with epilepsy. Today, we'll answer some basic questions about epilepsy and epilepsy surgery. What is epilepsy? What are some of the common treatments for epilepsy? Who are the candidates for surgery? And what are some of the surgical options that we have? First of all, what is epilepsy? A seizure is a temporary disturbance in the electrical activity of the brain. So our brain cells, or our neurons, communicate with each other with electrical and chemical signals. During a seizure, instead of the neurons firing independently and controllably like they're supposed to, instead they synchronize so that lots of neurons all fire at once in an uncontrolled manner. Depending on where in the brain that occurs, that can lead to a wide range of symptoms, from abnormal movements to weird sensations to a fall or loss of consciousness. Epilepsy is a disorder in which someone has recurrent seizures, multiple seizures. So a seizure is a symptom of epilepsy, but just having one or even a couple seizures doesn't necessarily mean the person has epilepsy. There are two main kinds of or classes of seizures, generalized and partial. Generalized seizures involve both sides of the brain. A person will have a change in alertness or lose consciousness. Common forms of this include an absence seizure, which is where someone sort of stares off and isn't aware of what's going on around them, and it may last for a few seconds and then they can just snap out of it. Tonic-clonic, which used to be called grand mal, where people have rhythmic jerking and stiffening movements. Tonic seizure with just the stiffening of arms or legs, or a clonic seizure with the repetitive movements. An atonic seizure is where someone has a sudden fall or loss of muscle tone. A myoclonic seizure is from the quick single jerks. So these can look like a wide variety of different things. A partial or focal seizure involves only part of the brain. A focal aware or simple focal seizure, a person is awake and aware that they're having the seizure. And depending on where in the brain the seizure is happening, they may have movements that they can't control, weird sensations, autonomic changes where their heart rate or blood pressure can change, or psychological or emotional feelings like fear or deja vu. A complex partial seizure will generally often start as a simple focal seizure where someone's aware of it, but then it can progress to where they have impaired consciousness. So who has epilepsy? There are 65 million people worldwide who have epilepsy. 3.5 million people in the United States per the CDC 2015 survey, and that includes more than 400,000 children who have active epilepsy. That includes more than 26,000 kids in New York State alone. Patients who have epilepsy are often controlled well with medication, but 20 to 30% of patients are medically refractory. That means that they're still having seizures despite appropriate medical management. Causes for epilepsy can be a wide range, from brain tumors, brain trauma, stroke or bleeding in the brain, an infection like meningitis, or it could be something someone is born with a malformation where parts of the brain didn't develop correctly as a fetus, or a genetic or metabolic disorder. There are a wide range of ways to treat epilepsy. The majority of patients will be treated with anti-epileptic medications. These will depend on the type of seizure or epileptic syndrome that the patient has. It'll depend on the patient's age, the acceptable side effects for them, whether or not they plan on having children soon, other medications they're on. Medications can control seizures in about 70% of patients with epilepsy. Of that group, about 50% of patients will be free of disabling seizures with the first AED or anti-epileptic drug that they try. About 15% will be seizure-free with the second AED. And there's minimal benefit with multiple drugs after that. Some patients are tried on, 5, 10, 15 medications, but really if they don't have any benefit from the first two, the chances of them having significant benefit from the fourth or fifth is very small. Some patients can benefit from a ketogenic diet. A ketogenic diet is a very low carbohydrate, high fat diet that forces the body into a state called ketosis, where it sort of mimics starvation. This is a difficult diet to maintain for a long period of time. It's more than just a low carb diet. It really needs the entire family to commit and change their meals in order for a child to stay in a state of ketosis for a long period of time. But it can be very effective for patients who are able to maintain it. It can decrease seizures by 50% in half of patients who can strictly adhere to it for a few months. And then there are also lifestyle modifications. For some patients, seizures can be triggered by sleep deprivation or by alcohol use or flashing lights. So trying to avoid those kinds of triggers can be helpful for some patients. Some patients, however, those things are not going to work for. And at that point, we start considering, are they a candidate for epilepsy surgery? Not every patient with epilepsy is a candidate. A patient has to have intractable or medically refractory epilepsy. So they've tried multiple medications, at least 2 or 3 medications, appropriate medications at appropriate doses to the limit of what they can tolerate as far as side effects are concerned, and they're still not having acceptable seizure control. If they're having real impairment of quality of life due to ongoing seizures, then they should be referred to a surgical epilepsy team like the one we have at Fareri and Westchester Medical Center. Once a patient gets sent to us, then we have to figure out, are they someone who could actually benefit from surgery? Does the patient have a single epileptic focus, one area of the brain that's causing the majority of the seizures that we could potentially take out? Do they have a different specific form of epilepsy that we can stimulate or disconnect? And can we potentially treat them without causing unacceptable impairment? So the way we determine that is by having a group of epilepsy physicians. We have epileptologists who are neurologists who specialize in epilepsy, neurosurgeons, neuropsychologists, neuroradiologists, advanced providers like PAs and APs and nurse clinicians. We have a whole team who really goes through and evaluates every individual patient. The history and physical exam are very important. We have to know what kind of seizures they're having, how often, when they started, what the risk factors were. Did they have meningitis as an infant or some sort of trauma, or is there a family history where they could have a genetic cause for their epilepsy? Those all affect whether or not surgery will be an option, and if so, what kind of surgery. We have to know what kind of medical therapies they've tried before, if they were on appropriate medications. We need to know the effect that the seizures are having on them and their family. The EEG and video EEG are incredibly important. What these are is where we actually monitor a patient in the hospital for several days of continuous monitoring. So it's not just an EEG that someone does at home for a few hours. They're actually admitted to the hospital, an EEG is placed, and they're watched on video for several days with a family member at the bedside who can push a little button when the patient has a seizure so that we know this is what their seizure looks like at home. And then we can see exactly what the seizure looks like and what the EEG looks like at that same time. So we can try to figure out where the seizures are actually starting from. Imaging is also very important when we're considering surgery. If someone has an abnormal area on the MRI, if they have an area of low metabolism on a PET scan or high perfusion on a SPECT scan during a seizure, these are all kinds of different imaging we can do to see what the brain is doing during a seizure or between seizures, or what it looks like to see if there's an actual anatomic problem in the brain. And those can help us figure out where the seizures may be starting from. Once we've determined if someone is potentially a surgery candidate, we need to decide if we think they can proceed straight to a therapeutic surgery or if they need a diagnostic surgery first. So a diagnostic surgery means we need more information before we know what we need to take out or stimulate in order to help their seizures. So this is something called an intracranial EEG. This is where we actually surgically insert electrodes into the head, so either on the surface of the brain or deep in the brain. This is very helpful if we don't know where someone's seizures are starting. If they have a lesion or a focus that we know vaguely where it is, but we don't know its exact borders. Or if they have a focus where we know where the seizures are starting from, but it's very close to or even potentially within what we call eloquent cortex, meaning the section of the brain that controls speech or movement, something that you don't want to injure and cause a problem for the patient. Doing the intracranial EEG can help us figure out what we can safely remove. So these are pictures of subdural electrodes. So to place this, we do something called a craniotomy, where we actually temporarily open up the patient's skull and place these electrodes directly on the surface of the brain. This allows us to get a really good mapping of the surface of the brain and allows us to do functional testing. So this bottom picture here, this area of the brain is where someone's language is often controlled. So if we think we want to take out part of someone's left temporal lobe, we'll actually put these electrodes directly on that area of the brain, and we can map and stimulate each one of those and see exactly which section of the brain to within a few millimeters is necessary for a patient to understand or use language, and which sections of that part of the brain are not necessary for that individual patient and therefore would be safe to take out. And this allows us to really map that area very well and figure out what we can and can't safely resect and what would be beneficial to the patient for us to remove. But this is a large surgery. Patients tend to have headaches. We have to keep these electrodes in for a week or two while patients are in the hospital being monitored. And it's relatively uncomfortable for the patient, although we do give them medicine to make them as comfortable as possible. So another option that we can do for some patients, which is a significantly smaller surgery, but still gives us a lot of information, is something called a stereo EEG, or depth electrodes. Instead of doing a large craniotomy where we actually make a large incision and temporarily take off the skull, instead, we can make tiny little 2 or 3 millimeter incisions and place these long, thin electrodes directly into the brain. So to do this, because we're going deep into the brain, the planning for it is very, very important. So ahead of time, the epileptologists will tell me exactly where they need to monitor an individual patient, what sections of the brain they need to study. And then on the MRI that we get prior to surgery, I'll go through and plan trajectories where I'll figure out how to study each of those sections of the brain without going through blood vessels or fluid spaces or parts of the brain that we don't want to put an electrode into, in order to make sure that we decrease the risks of surgery as much as possible. Then in surgery, in order to make sure that we're placing those electrodes exactly where we want them on the MRI, we use a robotic surgical assistant. That robot will load with the MRI and be able to show us exactly where each of these electrodes should be placed so that it ends up looking exactly like the MRI that we had planned. And then we can place each of these electrodes safely. We actually can screw them down to the skull so that they'll stay in place. And then we can watch patients have seizures that way. This gives us a lot of the same information that the subdural grids give us, although it doesn't allow us to map the function of the brain in quite the same way. So for some patients where we need to map out the function to study the language or the movement of a patient, sometimes the subdural grids will be more effective and beneficial for that patient. Other times, if we want to cover a wider area of the brain, where you can do both sides of the brain, then you can actually use the depth electrodes where we can really see what it looks like on both sides of the brain in a deeper area. For patients who have an MRI and an EEG that shows us where the seizures are starting, we don't have to do the intracranial EEG most of the time. We can often just do a therapeutic surgery where we can try to take out the section of the brain that's causing their seizures. A common form of this is something called a lesionectomy. So for patients who have a structural abnormality on MRI, which correlates with where the EEG shows the seizures are coming from, then we can often just take out that section of brain. This is often patients who have different kinds of tumors, cortical dysplasia, which is where parts of the brain didn't organize appropriately when the patient was in utero as a fetus before they were born, blood vessel malformations, other things that you can point to on an MRI and say, this is where there's an abnormal area, and that's where the seizures are starting based on EEG, so that's what we want to take out. Sometimes we don't know the exact borders of that lesion, and so we do need to do the intracranial EEG to get our safe borders. Other times we can do it just based on the MRI and EEG alone and take out that tissue. Another resection surgery that can be very effective is called a temporal lobe resection. Oftentimes patients will have what's called mesial temporal sclerosis, where if you can see this MRI, this part of the temporal lobe here looks significantly smaller than this one here. Mesial temporal sclerosis is where the middle part of the temporal lobe is a little smaller and abnormal compared to the opposite side. Oftentimes, seizures can be starting from there. If the patient's type of seizure, EEG, and MRI all seem to point towards temporal lobe epilepsy, then there are several different ways that we can treat that and have a very effective, very good chance at curing the patient's seizures. We can do what's called an anterior temporal lobectomy, which is where we actually can take out a section of the temporal lobe, the whole front section. We can do a selective amygdala hippocampectomy, where we just take out that middle part and don't have to touch this lateral or outside part. Different patients will need different kinds of surgeries for this. The larger surgery can be up to 80% successful at stopping disabling seizures for the correct selected patients. The smaller surgery may have a slightly less chance at being seizure-free afterwards, but it's a smaller surgery, which for some patients will have lower risks. So for each patient, we have to decide which is best. We often now also, for a lot of these patients, can offer what's called a laser ablation. And I'll talk about laser ablation in a moment. So an extratemporal resection means you're taking out tissue that's not in the temporal lobe, but is rather in the frontal or parietal lobes of the brain. The success rate is not as high as it is with temporal lobe epilepsy, and it really depends on the types of seizures and the focality of the lesion. So whether or not it's in one small area or whether it's in a larger area of the brain. If it is in multiple different lobes, or if it's cortical dysplasia, which can often have a wider spread area, then that's less likely to be seizure-free, but you can still get 40 or 50% seizure freedom in correctly selected patients. So resection surgeries can be very effective for the correct patients. A hemispherectomy is a larger resection, which is only offered for certain kinds of pathologies, certain causes of epilepsy. So if a patient has a large abnormality on essentially one entire hemisphere or one entire half of the brain, then we can help them a lot by disconnecting or removing almost that entire half of the brain, which I know sounds very drastic, but we only offer this in patients where that half of the brain is not helping them. They're not using that half of the brain. That half of the brain is really only there causing seizures and not being beneficial for the patient. So a lot of these patients, before we operate on them, they come to us already having difficulty moving fine movements on half of the body. They often will have a visual field cut where they can't see things on part of the visual field. They'll often have a weakness with walking on one side. And the younger the patient, the more successful this surgery can often be because the brain is still what we call very plastic. It's still able to heal and grow. And oftentimes the good side of the brain, the good hemisphere, can actually take over the function that was supposed to have formed in the bad hemisphere. So in appropriately selected patients, up to 50% can actually be seizure-free with a hemispherectomy. There are a few different ways to do these surgeries. The older way was something called an anatomic hemispherectomy, where you actually remove almost the entire hemisphere on one side. That surgery is generally never done anymore because there were too many side effects from taking out that much tissue. A functional hemispherectomy was done for a long time where we actually take out the temporal lobe and part of it's called the insula, different sections of the brain, and then disconnect the rest. So the parts of the brain that are left behind in that hemisphere are disconnected. So they're still in there, but no longer able to affect the patient. Now we keep moving towards smaller and smaller surgeries. So now what's often done is something called a hemispherotomy, where we disconnect and remove very small amounts of tissue. You may not remove any tissue, or may just remove a small amount of the temporal lobe, depending on each individual patient and what their pathology is. But generally, if you can disconnect that hemisphere, you can still get a very good benefit without having to actually take out that large amount of tissue. On the opposite side of the spectrum, instead of a large surgery like a hemispherectomy, we can often do an MRI-guided laser ablation, but this is only for small lesions or small areas of the brain. What this is we can actually go through and use a very thin laser probe, which can be placed into the brain surgically, and use a laser to heat up and burn a small area of tissue like mesial temporal sclerosis that we talked about for temporal lobe epilepsy. This is a very good alternative for some patients with medically refractory epilepsy. But because it's guided based on imaging, you really need to have an MRI visible lesion that can be targeted. Something that we can look at an MRI and say, this is the border of what I want to burn. This is what I need to take out. The rest of it I don't have to touch. I know how much I need to burn. Or sometimes patients don't have something you can see in MRI, but with those depth electrodes, that SEEG that we place, sometimes one or two of those electrodes will be exactly where the seizures are starting. And then you can actually go through and using that same navigation that we use to place that electrode, we can use that same navigation to place one of these laser ablation catheters and burn that area where the seizures are starting. It was thought that this required a minimum age of about 2 years, but we've done as young as 6 months with no adverse events as long as you're careful in placing the laser catheter. The chances of seizure freedom are smaller with this than they are with a larger resection, but again, the risks are lower too. So laser ablation, there's two main systems that each use different kinds of cooling systems and different kind of lasers, but they both do approximately the same thing. They both involve a thin fiber optic catheter, which can be placed under navigation, like GPS guidance in the brain, like that robot we saw earlier. You can use that to place these catheters into exactly the correct location in the brain. It just takes a 3mm incision in the scalp and a small burr hole in the skull in order to place the catheter through. Then the patient is brought to MRI to verify that the catheter is in exactly the correct location. The laser is then heated with the patient in MRI, and while they're in MRI, while the temperature is being heated up, we can actually, while the tissue is being heated, we can actually watch that temperature on the MRI. And we can set points to say that, the tissue next to it is normal tissue. We don't want to hurt that. I'm not going to let that go above a certain temperature but make sure that the tissue within the lesion does hit that temperature so that those cells are deactivated, are essentially burned and unable to work anymore. So it's really a way to target, to deactivate certain parts, small parts of the brain without damaging surrounding tissue. Patients tend to tolerate it very well, and they can usually go home in just a day or two after surgery. So those kinds of surgeries are taking out or burning or deactivating sections of the brain. Sometimes seizures are coming from large areas of the brain, and you can't just take out that whole area in some patients. So instead, you can sometimes disconnect or prevent the seizures from spreading. So kind of like with the hemispherotomy, where we disconnect almost a half of the brain, you can actually do that in smaller areas too without getting rid of any of the function in the brain. So a disconnection from something called a corpus callosotomy. The corpus callosum is a main highway that goes from one side of the brain to the other. And sometimes seizures are starting in one side and rapidly spreading to the other and causing patients to lose muscle tone and fall. And these can be very dangerous surgeries. Patients can fall downstairs, they can fall when crossing the street. So it's really hard to control a good quality of life for these patients. And so a corpus callosotomy can be very helpful for them. It may not stop the seizures from starting, but it can stop them from spreading. So instead of being a seizure that makes the patient fall, instead it can be a seizure that stays in one side of the brain and is therefore more easy to control and doesn't have the same effects for the patient and their quality of life. This is generally not going to be a curative surgery. With a lot of the other surgeries we talked about, the resections, we talked about chances of surgical cure or seizure freedom. These other surgeries now, the disconnection and the stimulation surgeries I'll talk about in a moment, are not going to generally offer a surgical cure to most patients. Instead, it's a palliative surgery. It's a surgery meant to improve quality of life and decrease seizures, or at least decrease the severity of the seizures. So about 50 to 70% of patients who have a corpus callosotomy will have a decrease in their seizures, but generally they won't have a cure. They'll often have a significant improvement in their cognitive function and their activities of daily living because they're not falling all the time and the seizure is not spreading so much throughout the whole brain. Oftentimes we only take the front 2/3 of the callosum. So on this sideways view of the MRI, this white or pale gray path here is the corpus callosum. And you can see here, the front 2/3 of it is gone, but this back part is still there. For patients who are able to read and write, we often are worried about affecting their ability to read language and the ability for language information to get to their visual cortex, which is the visual part of the brain in the back of the brain. And so we'll often just do the front 2/3 of the callosum. It decreases the risk of some of the disconnection syndromes, some of the problems you have when the two sides of your brain can't talk to each other if you can only take the front 2/3. Neuromodulation or stimulation is another what we'll call palliative treatment, a palliative surgery, a way to decrease seizures and improve quality of life, even if it's not likely to cure a patient. VNS is a device that's been around for a long time. It is placed in the chest with electrodes that go up to a nerve in the neck. It's always placed on the left side because the right side, that nerve is more likely to affect heart rate. It sends a stimulation up to the nerve, which then travels up to the brain every few minutes. And that can be programmed with different amounts of stimulation, different frequency. And for each individual patient, it can be tailored to them. There's also a magnet that comes with it that makes it go to a higher setting. So if somebody has an aura or can feel that a seizure is coming, they can actually swipe a magnet over their chest to increase the setting of the device temporarily in order to try to stop that seizure from coming. And it can have the option of a heart rate simulation where it can see if a heart rate suddenly changes. For some patients, their heart rate suddenly goes up when they have a seizure, and the device can be set to automatically notice that and fire at a higher setting if the heart rate comes up. This is FDA approved for patients age 4 and older, but we do use it in younger children and other kinds of seizures that aren't technically FDA approved. And it is very effective for other seizure types as well. Again, this is palliative, not curative. But about half of patients will have about a 50% decrease in seizures within 1 year. And it does get better over time. All of the stimulation procedures do seem to improve over time. At the beginning, you may not see a huge benefit, but once it's been in for a few months or a year or 2 years, you can start getting a significant benefit from it as it slowly changes the way the brain fires. One of the nice things about the vagal nerve stimulator is it also improves mood. It's actually FDA approved for use in depression as well as in epilepsy. And so it can actually improve patients' cognition and mood and allow seizure medication reduction, which can improve cognition and quality of life for patients as well. It also decreases SUDEP, or sudden unexpected death in epilepsy, once the device has been in for 2 years. The RNS, or responsive neurostimulator, is a newer stimulator. This one is actually placed in the head. The surgeon will place depth electrodes or subdural electrodes, like the ones we saw for the intracranial EEG. We can place those into the head and connect them up to a battery, where instead of having those electrodes come out of the scalp, they can actually connect under the scalp to a stimulator or battery which is implanted in the skull. That stimulator or battery has a computer in it, which can actually read an EEG from those electrodes we place. So patients can have their EEG read constantly 24/7 from this device. And whenever it sees a seizure, it can stimulate to try to stop that seizure from happening. So where these electrodes are placed will be based on the stereo EEG or the other EEGs that patients have that help us figure out where to put these electrodes. But in the correct patients, these can also be very effective at decreasing seizures. Again, it's not going to be a cure for most patients. But in the studies that were done, about 30% of patients were seizure-free for 3 months, and more than 10% were seizure-free for a full year. So it can still have a huge improvement in quality of life. This is FDA approved for adults with refractory partial onset seizures. It is also off-label when it's used in children or other types of seizures. So how do we choose? It's really very patient dependent. There are so many different kinds of surgeries we can offer, but they each depend on each individual patient, the kinds of seizures they're having, the kind of effect it's having on the quality of life, and what risks and their family is willing to take to try to improve their seizures. Obviously, brain surgery is never risk-free. So even though we do everything we can to keep it as safe as possible, we still need to make sure that families understand the risks that are involved with any surgery that we do. And so having patient and family discussions with reasonable expectations prior to surgery is incredibly important. And we always want to make sure that the families know that they can speak with all of us, with all the different members of the team, before we make any decisions and throughout the entire process, before, during, and after surgery. Our epilepsy team here consists of pediatric neurosurgeons, myself, Carrie R, as well as my partner, Jared Pasapia. We have fabulous pediatric neurologists who work with us. Dr. Wolf, Dr. Overby, Dr. Parvez, and nurse practitioner McGoldrick are all a wonderful team. We have a terrific neuroradiologist, Dr. Gomes. We've got endovascular neurosurgeons, Dr. Gandhi, Santarelli, and Al-Mufti, who help us with certain kinds of blood vessel studies and surgeries that we do for patients with epilepsy. A terrific neuropsychologist, Dr. Braniecki, and our wonderful physician assistant, Rachel Lehrer. This is our website, mariafrerichildrens.org/pediatric epilepsy program, and our phone number. Please feel free to call us if you have any questions about epilepsy or epilepsy surgery options for you or your family. Thank you.